without further ado, we are going to go across to the course tutor, Dr. William Davies. William Davies is a consultant psychologist and head of applied clinical psychology at the Association for Psychological Therapies. Courses written by him have been studied by well over 100,000 mental health professionals, meaning that his input will, at a conservative estimate, have influenced interventions with well over 1 million people. And for more, see Wikipedia, William Davies, psychologist. And we're going to try a bit of a hybrid system today where I am going to move the slides and Will is going to talk. So are you ready, Will?
Yeah, I think so. Nice to see people from Canada and Blackburn and Hull and India. That's nice. Fantastic. Fantastic. So are we away? Yeah.
I hope so. Yeah. Have you got the slide with the little birds on?
Yep. Lovely. It's absolutely
Lovely.
right. Yes. Yeah.
Okay.
So today we're looking at ABT's higher order therapy, which looks at, as the title suggests, higher order factors that occur across therapies. Who's moving it on? Is that you moving it on?
I'm moving it on, but there's just a little delay. 1 second. I think it really likes this slide. Just a moment.
Yeah. Yeah.
There we go.
Oh, lovely. Yeah. There's only some buttons work to move it on, isn't it? It's not like when you're doing a PowerPoint presentation. Anyway. So yeah, it looks at the elements that occur across therapies. You know, certain things keep cropping up, no matter what therapy you look at. Certain things keep cropping up. So these are in higher order therapy, and also the most effective elements that are in approaches such as CBT, DBT, ACT, solution-focused therapy, compassion-focused therapy, motivation interviewing, RAID, and so on. So some things are kind of only in one or two things, and we pull out the very best of those and put them into higher order therapy. But some things are really in right across the board. That mindfulness is in a lot of therapies. So obviously we look at mindfulness. So the aim is to master all the main effective elements in psychological therapy. So the idea, if you do higher order therapy, is that in a sense you've got everything that's relevant to being a really good therapist. And try and build them into an integrated approach. You get all the elements built in an integrated approach, and that's called higher order therapy. Lovely. So today's topic is assessment, because whatever approach we use, we need to complete a good assessment. It's really important to have a good idea of doing assessment. Do you know, I was looking at some research, and a lot of people only turn up for one session of therapy, which presumably in most cases is actually the assessment session. And when people got back to them and said, well, why didn't you come back? They've said, well, it did the trick. That's all I needed. So that is the power of a good assessment. It really helps. It's not just us that gets the assessment material, it's the patient as well. Has that data, it makes them realize what's happening, what their problem is, what their goal is, what they might be able to do about it, and so on. So today is assessment. If you do want more information on higher order therapy, go to probably the best place is www.aptonlinetraining.com. aptonlinetraining.com. That's probably the best place, I think, and then search for the higher order therapy modules, and it tells you all about them. And yeah, this event is completely free of charge. There's no facility for making voluntary contributions or anything else. It's completely free of charge, and it's part of our response to COVID-19. We've had some lovely feedback, thank you very much, probably from yourselves. It's saying it's kind of the one good thing about COVID-19 and so on, which is very nice. But thank you for that. And thank you for attending it. And feel free to invite other people to future events. This is for anybody who's interested. It's everybody's welcome. Sometimes people say, well, how many of these higher order therapy sessions will there be? Are we going to cover the whole of higher order therapy? And the short answer is we really don't know. Depends on two things, though. We do know that. How long COVID lasts, because we're keen to put something in to kind of compensate for this COVID thing we all have to endure, and how much interest there is in the sessions. I mean, at the moment, it's lovely to see so many people. There's 330 of us here at the moment. It's fantastic. So thank you so much for coming. That's lovely. Oh, by the way, I'm not sure whether, Amy, whether we've actually said how we're going or how it's going to take place. Have you, do you want me to do that, or what's...
Well, I was just about to, well, I was first of all going to see if it worked, and then I'm going to explain what we're doing, shall I? Is that all right?
Yes.
Okay.
I'm very happy to sit back and let you you grapple with Zoom, yeah.
Lovely, because we're going to try a bit of a hybrid system today, because the assessment section is all pre-recorded and beautiful. It is Will saying it all. So I'm going to play the recording. Then we love to hear all the comments and questions in chat. We absolutely love those. So when there's a little batch of them or a particularly good one, I am going to stop the recording and ask Will. You can ask Will absolutely everything. I used to worry about asking him difficult questions, but he loves them. So please, at any point, just pop anything you're thinking, anything question-wise, anything you're worrying about, into chat to all panelists, attendees, and then I'll stop the recording, speak to Will, and we'll move on. Is that all right with you, Will?
Well, that's excellent. I mean, I always think of you as everyone's spokesperson, and you do it incredibly well for my money. I think you do fantastic on it. So, yeah, I enjoy the difficult questions. Tell you the other thing I really enjoy, Amy, is the contributions that people make.
Yeah, really nice, isn't it?
Yeah.
Lovely. So wish us luck, everybody. I am going to try and press play and mute myself at the same time. So, but please pop everything in chat that you could ever want to, and speak to you in a minute.
Hello, and welcome to the APT's session on assessment. There was a time when I thought assessment wasn't really very important. I felt that if people came and told me what the matter was with them, and we just sorted out together pretty well. Let's spend most of the time on good interventions rather than assessment, I thought. And then I met a man who made me realize just how important assessment is. I saw a young man 10 years ago who taught me something about assessment that I will never forget. He'd been riding his motorbike along a main road when a car came out of a side turning and crashed straight into him. This resulted in severe injuries, obviously, particularly to one of his legs. I'm seeing him 18 months after his accident, when he was still off work, lost his relationship with his girlfriend, and generally had his life turned upside down. One of the results of this, or one of the facts he told me, was that he had severe problems sleeping. He found it very difficult indeed, and as a consequence was tired every day. Not surprising, I thought, not surprising at all. That's the nature of post-traumatic stress disorder. Nevertheless, for whatever reason, I asked him how much coffee and tea he drank. And it turns out he only drank coffee, 6 cups of coffee a day. And to be honest, I thought that was a bit much, but not really so much as to account for him being unable to sleep every night.
Just to show that the pausing system works, the comments have been lovely, but everyone was wondering whether we're meant to have the meerkat slide still up. And we are meant to have the meerkat slide still up with the audio. So it's just listening and admiring the meerkats and loving your comments. Thank you, everybody.
And I asked him how he made his coffee, and he said he put 2 spoons of instant coffee in the cup. That's not too strange. I mean, 1 spoon is the kind of standard, 1 rounded teaspoon is the standard measure, but even so, it's not too strange. So I asked him to show me, and we went into the kitchen. I was seeing him at his home, and he got out a dessert spoon, not a teaspoon, a pretty good-sized dessert spoon. And he stuck it in a bin of instant coffee and loaded it as high as anyone possibly could do, as though he was in a coffee grain carrying competition. So this was the equivalent of at least 4 ordinary teaspoonfuls. A dessert spoon piled as high as it possibly could be, like Mount Everest it was. And then he did the same again. So that made the equivalent of 8 teaspoons. So this is what he called a cup of coffee. And he did this 6 times a day. So he was having the equivalent of 6 times 8 cups of coffee, at least. enough coffee powder to make 48 standard cups of coffee. I asked him when he typically made himself coffee, and he told me that it varied, but said if we reckoned it was 11 o'clock, 12 o'clock, midday, that is, 2 p.m., 4 p.m., 6 p.m. and 8 p.m., that wouldn't be far wrong. He said he didn't have one late at night because he wanted to sleep properly. So caffeine has a half-life of about 6 hours. So if we just think about the 8 teaspoonfuls of caffeine he had at 11 a.m., he would still have in him the equivalent of 2 ordinary coffees at 11 p.m. So even the 11 a.m. coffee was like having 2 ordinary cups of coffee at 11 o'clock at night. And of course the other ones are worse than that. And if you actually do the math, it works out he is drinking roughly 24 ordinary cups of coffee at 9 p.m., which means he's still got 12 ordinary cups of coffee in him at 3 a.m. and 6 ordinary cups of coffee in him at 9 a.m. the following morning. Every 6 hours, the caffeine halves. It's a half-life of 6 hours. So to drink 24 ordinary cups of coffee at 9 o'clock at night is not a recipe for a good night's sleep. In fact, no one's going to get a good night's sleep with that much caffeine in them through the night. So to me, that's an illustration of how important it is to do a proper assessment. It would have been all too easy for me to be swept away in the awfulness of what had happened to him. And that, of course, is the main part of the story. That's really why I needed to see him. But equally, when it comes to helping him sleep, we want to do a proper assessment. In fact, when it comes to wanting to do anything, we need to do a proper assessment. And in sleeping, it includes simple things like how much caffeine he's taking. So that's what taught me the lesson I'll never forget. But let's have a look then at assessment. There's a nice checklist in the resources for this session, but I'll take you through it in some detail now. We need to do some detail.
Just before we start on the detail, can this be done remotely?
You're asking me, James?
Yes, please, Will.
Oh yeah, no. I was thinking that of course this is taken from the full course, as it were. So the people on the full course, they have all the forms and the exercises and so on. But I think what people need to have is a notepad and to take notes on whatever they want to do on the assessment, because it doesn't you don't get the materials as well.
But could you do the assessment remotely with people?
Oh yes, I beg your pardon. Yes, absolutely. Oh yes. Everyone's doing everything remotely at the moment. Yeah. Yeah.
So somebody was mentioning that it would be hard to do remotely, but you'd perhaps just have to plug in further about how big the teaspoons were, do you think? Or?
Well, absolutely. You can say, well, can you show me? Can you take me in the kitchen? And depending, see, not everyone uses Zoom. Sometimes they're on FaceTime, which a lot of people are used to and more relaxed on. And they can happily go into the kitchen and flip the screen and show what's happening in the kitchen and so on. So, yeah.
Yeah, super. Okay.
First, we need to know about the problem. We need to know not so much the diagnosis, but what the problem looks like. For example, if a patient tells us that he's depressed, we really want to know what he means by that. Is he simply sad? Is he also lethargic and apathetic? Does he have disturbed sleep? Is his appetite affected? What's his social activity like? And so on. If a person says they are anxious, then similarly, we want to know what they mean by that, whether they are referring to having obsessions or compulsions, or being anxious in social situations, or having panic attacks, or being phobic about spiders, or being generally anxious all the time, or what. It covers a multitude of things, doesn't it? The idea of being anxious. It's particularly important to ask these questions because there are only some diagnoses that patients volunteer to us. For example, we don't get many patients who say that they are suffering from a personality disorder. And yet those same people may say they are depressed or anxious or lonely or whatever. And our further questioning and talking to other people might help us make a diagnosis if we really want to. But remember that although many patients rather like a diagnosis, ultimately what most patients really want is to be helped. Still on the problem, it's good to ask when the problem occurs. With some problems, depression or generalized anxiety, the patient may feel the problem is with them most of the time. With others, self-harm for instance, they may say it occurs when they're lonely or under pressure or distressed in some way. Or with alcohol misuse, they may say it's constant, or they may say it occurs under certain conditions, social conditions at home in the evening, or whatever it is. In any case, it's often helpful to know when we come on to treatment, which is why we're doing the assessment in the first place. Often enough, you may find yourself talking not to the patient, but somebody who looks after the patient. For example, a parent, or if you work in residential facilities, nursing staff. So a parent may say their offspring is rude and aggressive, like lots of parents do. Nursing staff may describe the disturbed behaviour of somebody in their care, and so on. But the same principles apply. We talk to the parents or the nursing staff or whoever it is in detail about the problem and what they know or believe about the problem. Similarly, with the patient's permission, we may be able to get important additional information from their significant others, their partner or friends or whatever. It really doesn't matter who we're talking to, the patient or their significant others or professional colleagues. Our job is to find all the information that's available and to collate it. This includes going over any notes about the patient very carefully, and this is why often enough we will actually know more about the problem than the patient will know themselves. Oftentimes the most important information actually comes from significant others. An example of this is where a patient comes complaining they are irritable or angry or aggressive at home. And then we must get a measure of the problem. This can be objective or subjective. An example of an objective measure would be where you're working with somebody who is destructive or aggressive or loses their temper. And one objective measure might be how often they smash things up. There are plenty of people who smash things up, and the frequency with which they do it is a very good measure of how well they are progressing, so long as it's reducing, of course.
Sorry, Will, are you ready for another question?
Yeah, why not?
How important do you think it is to have a diagnosis for patients to decide what their treatment options are?
Well, good question. It all depends what the problem is, I think. For instance, if the person is depressed, then they need to know that the treatment options might be CBT or interpersonal psychotherapy or whatever, or it could be antidepressants. Now, of course, as a psychologist, I would say surely they prefer to have CBT or IPT rather than antidepressants, but that's not the point. It is the patient's choice. So in something like depression, that's absolutely a good thing to have a diagnosis like that. Something like personality disorder, not really. There isn't a clear sort of medical intervention for personality disorder, and so it's less relevant there. So sometimes it all depends what the possible diagnosis would be, is the answer.
Super, thank you.
Plenty of other people and plenty of other complaints. Subjective measures are actually best. Although objective sounds like a better thing, subjective measures are best with lots of things. For example, with a depressed person, you might ask them how they've been feeling over the last week, using a 10-point scale where 10 is the best they've ever felt in their whole lives, and 1 is the worst they've ever felt in their whole lives. The APT progress form I've put in your resources for this session is great for this. And you can make up your own question to ask the person every time. Really relevant question that would really hit it on the head. There's examples of the kind of questions you can make up on the form itself. And so long as you ask the same question at the same point in the interview every time, then that is a really good measure of progress, super measure. One final point about talking about the problem. A lot of people like a solution-focused approach to therapy, myself included. But even if you have a solution-focused approach, it is very important that you become an expert on the problem. Of course, you're going to work around to some very good solutions, but it is the problem that first brings the person in to see you. That is what drives them. And no amount of fudging about the problem and talking about solution-focused approaches and so on helps you to get a great solution. Clarity on the problem and excellent solutions fit hand in hand. You next need to investigate whether your patient's symptoms serve any purpose or function for them. Very important. We're going to come on to this later on, later session, but it's important to do. And I find the phrases such as, your problem sounds very distressing, but are there any silver linings to it at all? Is there anything good? Is there any good side to it at all? Those kind of phrases can work well. Or, is there anything you would miss about it if your problem disappeared? Surprising how often you'll get a positive answer to this. For example, with people who have a substantial drink problem, there's still some compensation to it in terms of reducing anxieties and getting away from unrewarding circumstances. Even the apathy and lethargy associated with depression is reported as having some payoff by many patients who find it lessens the pressures of everyday life. So it is vital that we look for these unintended effects of the problem and see how we can help the patient to obtain the same benefits in a much more helpful way or less destructive way.
Okay, I've got a few questions coming through. What are the areas a clinician can explore when a patient is in denial of their diagnosis? Oh, I think you're on mute, Will, when you've got a mo.
Yep, there we go. When they're in denial of the diagnosis, what can they explore? Well, I think you can, they call it Socratic dialogue, don't they? You talk to the patient and you ask them lots of questions. And of course, the more, I wouldn't say pointed, but the more pertinent the questions are, the more the person begins to think, well, maybe there is something here. So it is a question of asking questions and allowing them to think things through, I think. You can even do that with psychotic people. It's at its best, in a sense, for psychotic people, you know.
And Kirsty was so busy writing about objective measures, she missed it when you said what subjective measures were, if possible.
Oh, well, a subjective measure would be something like, out of 10, how would you say your mood has been over the last week? That'd be subjective, you know. Out of 10, how irritable have you been over the last week? Out of 10, how anxious have you been over the last week? Those sort of things.
Super.
Whereas an objective measure would be, how many nights did you have a drink this last week? Well, that would be, you know.
Haley's asked if it's like scaling.
Yes, exactly like that. I was noting that I mentioned we're not able to give you the resources, I'm afraid, because this is a course that people actually buy. And in the free version, we can't give away the resource. Amy and I are happy to give our time, but we can't actually give away the APT's resources, I'm afraid. But it's the form that I mentioned is easy. It is just those questions, like out of 10, how's your mood been? Just ask that question, same time in the interview every week. And that's a really good measure.
Do you have an example of a pertinent question regarding a diagnosis?
A pertinent question regarding a diagnosis. Yeah, if you have a diagnosis in mind, for example, well, let's take schizophrenia. We just mentioned that, and psychosis. There's questions like, do you hear voices that other people don't seem to hear? That's the kind of thing. So you have to the diagnosis you've got in mind. Like in depression, it would be something like, would you say that you're constantly or often lacking in energy? Would you say that you're often low in mood? And so on. So you know what the defining characteristics are of the diagnosis are, and you ask those targeted questions.
Super. Okay.
This is important and interesting, and as I say, we're going to look at it in a later session. Then we have to ask the patient what their goals are. Often enough, the goals are obvious. It's to get rid of the problem. And some writers can be cynical about such goals referring to them as dead person's goals, meaning things that a dead person would do better than a live one. For example, not drinking, not feeling anxious, not being depressed, and so on. In fact, more or less anything that has the word not in front of it. For myself, I think maybe we can be a bit too cynical sometimes, and I don't mind such goals. It seems perfectly reasonable to me that people who are anxious want to be not anxious. Having said that, it's often helpful to invite the patient to turn the goal around. For example, if they say they want to be less depressed, then to ask, for instance, is it just less depressed you want? Or is it to be the opposite of depressed, like energetic, settled, and active, for instance? Sometimes turning it around like that can help the patient envisage it better, and it can feel more motivating, and it really tells us what we're aiming for. It is a great area for discussion, and helping people get really clear on their goals is great fun, because it is the stuff of pure fantasy. You're not asking them to go off and immediately take difficult actions. You're just discussing with them what their ideal end result would be, what their ideal goal would be. Incidentally, it's also important to find out what a passable goal would be. In other words, how far along the road you have to get before you can stop therapy, or even before you should stop therapy. Because we need to bear in mind that if we undertake to work with the patient until their lives are perfect, then we are going to be with them forever. Next, we need to ask the patient what positive or protective factors they've got going for them, because we want to use these positives when we come to constructing a treatment plan. The kind of things we're looking for can be anything ranging from financial security, through good supportive relationships they've got, helpful personality characteristics they have, or being in a job that suits them, or functioning okay intellectually, and so on. These are all things we may want to use in building a helpful plan with, or we should be wanting to use with building a helpful plan with them later on. And these things might have become a little bit obscured, overwhelmed by the problems that are going on.
Question from Camilo. Would it not be better to ask open questions regarding mood? For example, better to ask, how has your mood been today? When you get low mood, how long does it last?
Yeah, I think open questions are terrific, and I think they are the staple diet of therapists. Standardly, we ask open questions. But I think both open questions and closed questions have their place. And if you go to an optician, for example, and they'll say, which one is better, this one or that one? Giving you two different lenses. If they asked an open question about the same thing and said, well, how can you see with this one? Oh, well, how can you see with this one? It would be hopeless. So both open and closed questions have their place. For example, in the clinical world, I've worked a lot with forensic patients. And if you're asking people what they, for example, sex offenders, if you ask them what their sexual fantasies are, you don't really get very far. An open what question don't respond to that. Whereas if you ask closed questions, do you think about X or do you think about Y, you do get replies to those. So you have to have a mix of open and closed questions, I think, and that applies to most things.
That's good.
Then we want to ask about any current treatment they're having and any past treatment they've had. We want to know what works and what doesn't work. We don't want to keep doing things that have not worked in the past, and we do want to keep doing things that have worked in the past, or to reinstate them, or maybe even refine them. Things that work to a degree can often be refined and improved quite a lot. Even the taking of medication, or if the patient finds that helpful and positive, or various psychological strategies, relaxation or whatever, even these can be refined and improved. Maybe not directly by us, but maybe one of our colleagues or whatever. Later on, when we've got all the information we think we need, we're going to make good sense of it. And part of that's going to be to work out where the problem came from and what's maintaining it. So a great thing we can do at this stage is to ask the patient exactly those questions, what they think caused the problems and what they think keeps the problems going. And by implication, of course, what might stop the problem. And when I say ask the patient, I also mean ask the patient's parents, if that's who you're talking to, or the patient's nursing staff, if that's who it is, and whoever it is. I mentioned in passing that we should ask the patient any plan they might have for resolving their problems. And this can be very important. When I was training, I made my reputation in one hospital by curing an agoraphobic patient. Somebody had been agoraphobic for 20 years, actually, in 5 weeks. And it was absolutely easy because I asked him whether he had any idea as to how he could resolve his problems, how he could cure himself. He said, yes. I think I should walk to the bottom of my garden several times a day for a few days, maybe, probably for a week or two. Then I should venture out through the garden gate every day, again, several times a day for a few weeks, but only just out of the garden gate. That's going to be a big step. And then maybe a few steps along the pavement, but only a few steps. And then I should try and make it perhaps maybe halfway to the shop on the corner of the street. Again, 2 or 3 times a day, do it lots of times, over a couple of weeks maybe, and then finally see if I can make it as far as the shop and call in there, perhaps several times a day, at least while I'm doing my treatment. I was amazed. I mean, it was like he had read it from a book. All I had to say was, that's perfect. That's a perfect plan. And to monitor him as he did it. And it was a perfect plan, and it worked perfectly. And we were both very pleased with each other. So I've always remembered that, and now it's always worth asking the patient whether they have any ideas.
Just a bit of a discussion with with goals and values.
Yeah.
Would it not be useful to think with the person about their values, what's important to them as a person, what kind of person they think they are, and what kind of person they want to be?
Yeah. Well, that's straight out of ACT, of course, isn't it? Straight out of acceptance and commitment therapy. And it's usually regarded as an intervention. And would it not be useful, you ask? Absolutely, it would. I think it's a super intervention. I think it's absolutely core to what makes us people, and fantastic intervention. And you might say, well, surely it's also a bit of an assessment as well, isn't it? Because it is information about the person, isn't it? And one piece of information is they may be totally unable to tell you the answer to that question. They have no idea what their values are, which is information in itself. And if you're using an ACT approach, you'd know that's going to be a very important element to identify.
Some patients have read a lot about their problem and can give you a textbook solution. So sometimes all we have to do is give them the courage to do what they've worked out, and maybe give them a bit of support that they can phone us up if they want to, halfway through the week. Next, you need to ask the person about what they do, their behaviour. What they do is their life, how they spend their day, looking all the while for anything connected with their problem. For instance, Lewison said that the reason that most depressed people are depressed is because they lead depressing lives. Well, that might be exaggerating a bit, but equally there is something to it. So if you're seeing someone who is depressed, then it's well worth looking at exactly how they spend their lives, what their lives are like. Equally, if you're seeing someone who is anxious and they spend all their time working out how they can avoid doing things that make them more anxious, then that's a clue too. Maybe they'd be better off working out how to gently confront their fears, because it can be anxiety-provoking in turn, trying to work out how to avoid things that make you anxious. You worry that you might not be able to. Then you need to look at things biological, past and current medications, any illnesses they've got, what exercise they take, if any, what their diet is like, what the daily rhythm of sleep and waking is like, how much sleep they get, any notable medical aspects at all, and of course, endemic drugs like caffeine and alcohol. If there's any possibility that what the patient sees as psychological symptoms are actually caused by something biological like an illness, then this needs checking out. Things like hypothyroidism, for instance, can mimic depression really quite closely. But apart from illnesses, just routinely, there are biological interventions to be made that will have major benefits for the patient. I believe the idea that mind and body are separate is a very outmoded one. If you improve the biology, you improve the mental state too. Next, you need to look at the person's emotions generally, quite apart from the ones they may be telling you about in relation to their immediate problems, because very often people come, the emotions is what they're complaining about, being depressed or sad or whatever. And including any past traumatic events that have happened to them, emotions that are left over from those. And then, very importantly, you need to talk about the person's surroundings, and in particular, their social relationships. Relationships with their partner, if they have one, or their feelings about not having one if they haven't. Thoughts about previous partners, if any, but certainly about their general social situation and history. Relations with neighbours, friends, people at work, and so on. So their social surroundings, if you like, but also their financial surroundings, their financial situation, which is often enough tied up with a person's problems.
Okay, a couple of juicy ones. With regard to personality disorder, how do you explain this in a positive way so the patient understands this and is accepting of this, especially if the person has previously been misdiagnosed?
Good one. To be honest, I don't think the label personality disorder is very well accepted by many people, so I tend to avoid using that label. And instead, what you talk about is what they do. So, of course, the point about people who have a personality disorder is they do things that don't work well for them. So you will be able to find plenty of things that they do which haven't worked well for them. And again, it's a question of asking them the question and say, well, what did you do in that situation? And how well did it work for you? And what else could you have done? And would that have worked better? And so on. So taking them through the kind of situations that they respond to badly and looking at how they could respond to it better. But typically, funnily enough, I did come across some just recently, who said that she had been diagnosed with borderline personality disorder. And she didn't mind telling me that. But that was just a social situation, strangely. But generally, I don't think people like to have a personality disorder. As opposed to one of the more popular, one of the more least sort of, people don't mind so much having the diagnosis of bipolar disorder, for instance. But that's because perhaps, I don't know why that is, but some celebrities have that as a diagnosis, don't they?
And is it beneficial to use more than one therapeutic approach?
Yes, I think so. And that's the cornerstone of what we're talking about in higher order therapy here. I think it's nice if things are integrated and never contradictory and all seem to be pushing in the same direction. But I think you have to be knowledgeable about a range of therapeutic approaches. So that, for example, somebody mentioned earlier, getting people's values and principles and so on. And if that's relevant to the person, yes, we need to know that's important and move ahead with it. If something else entirely is relevant to the person from a different kind of therapy, then we need to know about that and use that. And that's the whole point about higher order therapy. We're trying to cover everything that is relevant.
And Pauline's made a good point. Asking the client how they themselves think they need to tackle their problems is a great indicator of taking responsibility for change too. Also, useful to ask the opposite. What is the likely outcome if we don't go ahead with these plans? Which can also be a good motivator in exposure work.
Absolutely, yes. Pros and cons of acting and pros and cons of not acting, yeah.
It's quite difficult to ask people about their thinking style, but if you do have any observations about the person's thinking, then it's worth noting them down. For instance, if they tell you about previous therapists, and all the previous therapists have either been incredibly marvelous or absolutely terrible, then you might wonder about whether they've got a habit of thinking in extremes, all or nothing thinking, or if they're constantly talking with suspicion about others that they've come into contact with, at home or at work, then you might wonder about their core beliefs about other people, and so on. Any observations that you've got about their thinking style can be very important. Then we have to look at factors that are specific to why the person came to see us. For instance, if they are depressed, you'll be looking at everything above, perhaps especially the nature of the life they lead. But what about if they have anorexia or suspected anorexia? Clearly, you'll want to have a close look at what they eat, very close look at what they weigh, and so on. And what about suspected psychosis? In that case, we want to ask about any unusual ideas or unusual beliefs they have. Of course, we all have unusual ideas and beliefs, but we will want to look at these particularly closely if there's a question of psychosis. And also to ask about whether they hear any voices that other people don't seem to hear, and so on. The general category is questions of obvious general relevance to the possible diagnosis. My fantasy for this one is of a judge. Judges tend to have exemplary common sense and clear-cut questioning. Saying to me something like this: so this person came to see you because there was a possible diagnosis of anorexia nervosa. Well, did you ask them about their eating habits in detail? And did you weigh them and work out a BMI figure? This is never going to happen. We're never going to be hauled before a judge and asked these questions. But I find it a very helpful image. I think having a yardstick for what you should ask is a very good one. And I find that a very good yardstick, no matter who you're seeing. In the same vein, the next category is follow-up questions. These are questions you ask because of something the patient has told you. For instance, the young man I told you about at the beginning, who said he was having great trouble sleeping following a terrible road traffic accident. My imaginary judge in this instance says, so this young man told you that he has difficulty sleeping, that his mind is racing through the night. Did you ask him how much coffee he drinks? And as you recollect, he drank an amazing amount of coffee. But the whole case was so sad, it would have been easy not to ask about his caffeine intake. That sounded a little bit superficial. But I think this is actually a big category, actually, the follow-up questions, because people tell us all sorts of things once we start asking them about the problem and their goals and what they think underlies the problems and so on. So there's a lot of natural follow-on questions, questions which we really should ask, either in that first interview, assessment interview, or in later interviews if we're worried about overloading the patient. And finally, you do have to ask or assess in your mind the degree of risk the person poses to themselves or to other people. Now, you're not normally asking directly here, it is, but assessing in your mind. The major risks are of suicide and self-harm, which you can actually ask about directly. Self-neglect, not taking care of themselves as much as they should. Impetuous behaviour of various kinds. And risks to other people in terms of violence or sexual assault or neglect of dependent children, or even in extreme cases, the possibility of taking other people with them if they take their own lives. And this has actually happened in a case of people in charge of public transportation of various sorts. It is, to be fair, very rare though.
Why would you not ask directly about risk?
Well, very good question, because some things you can ask directly, even some very sensitive things like, do you think you might kill yourself? You have to find a form of words that you're happy with, but absolutely you can ask directly if it seems right. But a lot of risk, for instance, a risk of violence. Are you going to attack so-and-so? The probable answer is going to be no, because they'll probably be detained if they pose a risk of attacking somebody. Equally, self-neglect. Not for a different reason. If you say to somebody, are you neglecting yourself? Sometimes you get a good answer, to be fair, but a lot of the time, the person who's neglecting themselves doesn't view it like they're neglecting themselves. That's the way they live. So yeah, it's perhaps a bit extreme to say never ask a person directly, but you don't always get a full answer from it.
And could you give examples of impetuous behaviour?
Yeah, We had one just recently. I mean, it is associated with borderline personality disorder or emotionally unstable personality disorder, as ICD-10 says. But for instance, there's a person I described on a previous session where she was waiting for her boyfriend to arrive on a Saturday evening, and he arrived late and hadn't booked a restaurant at all. So she said, "Well, get lost, forget about it then," instantly. And equally instantly, 2 instants later, she regretted it. By that time, he'd gone. But just almost immediately, she regretted it. It's like she didn't have a kind of filter. Things came out before she filtered them and before she responded in the way she really wanted to respond.
Is that similar to impulsive behaviour?
Absolutely, yes. Impetuous and impulsive, pretty much synonymous. Absolutely right, Hayley, yeah.
And how might you ask indirectly about risk? For example, self-neglect.
Self-neglect. You might say, what would you typically have for your lunch? Oh, biscuits. Oh, righto. And what would you have for your tea or your evening meal? Biscuits. Righto. And breakfast? What do you have for your breakfast? And on. So you can talk about how people feed themselves, how people wash themselves, and how people generally care for themselves. What time do you go to bed? Oh, it depends. What does it depend on? Well, it depends on what time we go to bed, really. Could be 1 a.m., could be midday, could be anything. And as a result of those kind of questions, you make a judgment. And people sometimes like that will say, no, I'm happy with this. But you can make a judgment. And if they are clearly in the end result of having neglected themselves, then you make that judgment.
Super.
So there we are. You should now have a terrific amount of information, either from the patient or from those who are looking after the patient professionally or by way of family or anybody else who's relevant. And you will ideally have taken some sort of subjective measure using the progress form, getting an out of 10 rating for whatever is relevant. You might have used other questionnaire measures in relation to personality disorder or measures of depression and anxiety and so on. But one way or another, including objective measures as well, you will have a stack of good information, and your next task is to make sense of it and to make sense what might be the best plan to help the patient. And that, of course, is a later session, which we'll cover. You've done a great deal of spade work now, though, and I'm sure you'll have an idea about what's going on with your patient. So in that session, we'll look at that really thoroughly and see what we can uncover.
Sorry, so I think that's everything. But so a couple more questions. Are there any examples of indirect questioning on suicide?
Not really, to be honest. And there is data that if you ask people directly, they are much more likely to tell you. So that is a very good example, actually, Elizabeth, of how it is a very good idea to ask directly. I think the figure is reckoned to be something like 9 times more likely if you actually ask directly than if you wait for them to tell you.
Super. What about looking at psychological mindedness, flexibility, suitability for treatment?
I'm not sure about that because I think we have to take patients as we find them. I'm not sure about the whole question. I know that's correct, that people do bring that one up. It is a sort of thing you read in the textbooks even, suitability for treatment. Well, the person has arrived for treatment. So it's not for us, in a sense, to judge whether they are suitable for it. That's the person we have. And we're going to do our best for them,
Sounds good. So I think that's the end of the audio. So if anyone has any further questions, Will and I always stay around to read your chat. There's been some lovely comments in there too. So if anyone wants to have a look during those, that's really good. Have you got any more to say, Will?
Well, there's just a couple of questions I noticed, actually. I haven't been monitoring as closely as you have, but One was, can a teenager be diagnosed with personality disorder? And I must admit, I think that's a little bit of a sensitive one, because my answer would be no. And yet you hear teenagers being diagnosed with emerging personality disorder, which I don't like. It is a label, but it's not a label I like, to be honest. How would you know that somebody has an emerging personality disorder? And teenagers, their brains are developing. They are not fully developed. So you cannot predict they're going to have a personality disorder. So yeah, it's a little bit of a bee in my bonnet. And the other one is, the other one I noticed was, if you've got ADHD, can that have another diagnosis alongside? And the answer is absolutely yes. Having ADHD does not protect you from depression or anxiety or anything else.
So there's some lovely comments coming through in chat. So they shoot by a bit quickly now. So I'll put some music on and we'll have a read through your chat session. So it's a lovely thank you. There's been some really lovely appreciation. So we really love reading your lovely comments. Thank you. You got anything more, Will?
Well, no, just to thank you, to be honest, Ames, because we are incredibly busy at the moment at the APT. So we're all working all the hours. But so to put in this extra bit is really, really nice, I think, and very enjoyable and very rewarding. So thank you for doing it. And thanks everyone for coming.
I love it. It's a highlight of my week.
That's right.
Hopefully see you next week. We'll do another hot topic next week. See you all soon.
Yeah.